Good enough. Welcome, Chris, Alex, and the wider team. This is one, as you know, in a series of public accountability meetings for all health organisations. We have a section of the team here from the Welsh Government, and you have representation from across your board. There's a lot of us in the room, but I would suggest that rather than introduce ourselves at the start, perhaps each individual can introduce themselves the first time they speak, so the public knows who is here. The meeting is being live streamed, and there are translation facilities available both in the room and online, so please do feel free to contribute in Welsh or English as you wish. Thank you for the evidence pack which the board submitted, which the organisation submitted in advance. We've got an agenda which is intended to cover 4 areas. One is the work which you're doing in relation to educating and training the current workforce. The next area will be looking at the changing workforce and future needs. The third area will be in relation to improving leadership capacity across the system. And the last will be steps which you're taking to strengthen the organisation itself. The evidence pack touches on all of those and has given good assurance in a number of areas. So the areas that we'll focus on today are the areas where we want to understand a little more about what the board is doing, what the organisation is doing, and the board in particular is doing in those areas. 1 or 2 of the points which I'll raise have been issues of public interest or correspondence occasionally, so to reflect the priorities which the public viewing have raised with us and no doubt with you as well. At the start of each section, I'll ask somebody, Chris, from your team to set the scene from your point of view, and then we'll get into the questions. I hope that could be done briefly, because that gives us more time for us to be able to have the kind of discussion that I know that we all want to be able to have. Before we get into the agenda, Chris, is there anything you'd like to say by way of opening remarks?
Well, diolch am y cyfle. Thank you for this opportunity, and we very much welcome to have this discussion and scrutiny. I want to emphasise the organisation's feet are well and truly in the NHS. We're a special health authority, and we were established to bring coherence and strategic focus to the development of the health and care workforce. And to enhance the accessibility of training, reinvigorate and strengthen leadership development from a very low base, transform workforce planning and workforce data, and drive innovative workforce models through integration with service and digital transformation. We are very focused as a body on the I in HEIW, namely maximising value, benefit for learners, staff, patients, and most importantly, the population of Wales. We believe our agenda speaks very strongly to the Future Generations Act. We aim to be the best of partners. And I think everything we do is based on strong communication, engagement, involvement, expertise, quality assurance, culture, well-being, and evidence-based data and analytics. And these are very key ways for us to work. The board is focused across strategic planning. We have our feet in today, and we have our perspective into tomorrow. So actually basing issues around futuring are really important, but they do not override how we react and respond to today. Our staff offer specific expertise straddling both NHS and education, which is fairly unique. Our tutors, trainers are embedded in the NHS frontline care, and our trainees and students are all involved in patient care during their training. Through this government's investment, I can tell you today that we have in excess of 12,500 people, individuals who are training, and most of them are involved throughout their training in direct patient care. You've mentioned our evidence pack, and we've tried to keep that actually on message to this agenda. I'll finish basically in saying to you our commitment, our enthusiasm, and I think our developing expertise is towards Once for Wales solutions to support our health boards. It's certainly focused on improving the outcomes for patients. And I can tell you now, our capability and capacity to work in an agile issue-solving approach is developing, and the long-term scenario building, which will be essential for a fairly unpredictable future, given the velocity of change in technology, data, and particularly AI. I think that is strengthening. Thank you for that opportunity.
Yeah, Chris, thank you very much. We'll obviously pick up on a number of those themes as we go through the agenda today. Okay, so the first item on the agenda relates to the work which you're doing to meet the education and training needs of the workforce today. Who'd like to open the view on that, Chris? Alex.
Let's do that. Thank you very much. Alex Howells, Chief Executive of Health, Education and Improvement Wales. So just to highlight a few points, as the Chairman has already alluded to, we are spending £320 million on education and training this year. That's 84% of what we spend as an organisation, so really important we get the value from it. And it is the most important plank in our future workforce supply. So we undertake planning, and since COVID, our focus has been very much on addressing some significant workforce deficits that were driving cost and quality issues. And through our annual education and training plan, and with your support in Welsh Government, we have been able to increase investment. That's enabled us to really strengthen the domestic training capacity and infrastructure in Wales, to expand places across the majority of professional programmes, and also to get a better geographical provision to better meet the needs right across Wales. The planning takes account, as you'll see from the pack, of lots of different inputs and contributions, different external factors that are changing, but critically is also based on the local workforce plans that come from NHS organisations. And you'll see from the pack that we're also working closely with them to try and improve the quality and consistency of that local planning. We also then have a key role in implementing that plan, and that's really where we get the value from all of that investment and that time. And we have comprehensive commissioning frameworks in place with our NHS partners and our higher education partners to deliver on that. And through working together, we have been able to achieve generally positive recruitment and improving fill rates across the majority of professional programmes. There are some notable exceptions that we spend a lot of time on, like nursing, and will continue to do so. We have a strong focus on waste and making sure that attrition is as small as possible and that we encourage people to complete successfully in their programmes. And a really proactive and supportive approach with NHS colleagues on quality management with a real focus on the learning environment. So the value for us is more than output from the programmes. The value is how we maximise impact on the NHS workforce. And that's a real key area of focus for us at the moment, that transition point from education into employment pipeline. You will know we've had a few bumpy issues with that over the last 12 months, and it's been really disappointing that students have been concerned and disappointed by perhaps not thinking that they might have jobs in the NHS in Wales. And obviously we are now acting on that to make sure that we use the better data that we've been able to produce in HEIW, and we've put in place a more collective mechanism to make sure that we take a joined up approach to trying to predict and manage those over and under supply issues going forward. But looking ahead, I think what we would say is we're building on strong foundations, but we can be better and we want to be better. And I think that what we'd really like to do is to use the real improvements in workforce data we've delivered to do a much more national population focused approach to workforce planning going forward, and recognise that with the challenges ahead, we can't recruit and train our way out of those challenges. We all need to be working together on integrating service, digital and workforce transformation to make a sustainable NHS Wales. So thank you very much for that opportunity.
Thank you. So I would sort of pick up on some of the points which you made. So Chris, one of the things I'm interested in exploring with you is how you work with health boards to identify needs. So obviously we're recruiting more people than ever before into the health service. There are still some key vacancies. That's one challenge. Another challenge is, I think you described them as a bumpy ride or something, Alex. So the particular areas where there have been, some examples recently in nursing and in paramedics last year, where we've got people graduating and then it's been a little difficult for them, at least temporarily, to get visibility of the employment. So are you content that the arrangements that you've got in place, the relationships you've got in place with health boards are as effective as they can be? And where do you think the accountability lies in the system when those situations arise?
Can I pick up on that one? Thank you very much. I'm going to bring Helen Watkins in a second, who will explain what we're doing at the moment. Helen's our Director of Workforce and OD. So I think in terms of the relationships with health boards and NHS trusts on the workforce planning side, there is a well-trodden mechanism of making sure that everybody inputs to workforce planning. But I think we've recognised that what's served us well for many years now needs to change to respond to changes in environment. And so we are in the process of strengthening those arrangements in order to address some of the issues that we've had. But I'll let Helen pick that issue up if that's good.
Yeah. Thank you very much, Helen Watkins, Director of Workforce and OD. As Alex has alluded to, we've experienced some bumps in the road, and I think we probably we were surprised last year in a way that maybe we shouldn't have been, and I think we've absolutely learned from that.
What do you think was behind that, Helen? What do you think was behind the surprise, as it were?
I think probably communication, and I think using some of our data, and we've absolutely recognised that, and we've learned from that. As soon as we became aware of the situations, we engaged with organisations, and not just the organisation that was experiencing the particular issue, but also neighbouring organisations, to start to bring in a more regional approach to solving some of the issues. And that's been really well received. I think our partnership approach, regular engagement with those organisations. So if I take, for example, the situation with the paramedics, we were meeting weekly. We now have a monthly routine with them where we're talking about what the situation looks like, what does their data look like, understanding what some of the issues have been, whether there are issues with the course, and what whether the education is producing the workforce that Welsh Ambulance Service actually needs. And those are ongoing conversations that we're having. To enable us to do that, we're now foreseeing what's coming up in the summer. I think the other part that we've done as a system now, we've introduced a new group, and it's not all about a group, but actually this is the first time as a system that we've had executive representation from all organisations around the table, actually looking at our supply, looking at the data that we are now able to provide to anticipate some of the challenges that we've got, and understand that data better to be able to respond in a more proactive and managed way.
So would you say that, I mean, my interpretation of what you said is that there isn't a sufficiently dynamic understanding of changes in either the skills mix which the system needs, or perhaps the gap, the relationship between retention, which we're doing better at generally, and recruitment. So there isn't a sufficiently dynamic, real-time understanding. And is that a fair way of putting it?
I think we're in a position now where we have data where we haven't previously.
Okay.
I think we have, as an organisation, have invested in our data provision and sharing that data and making that data available and using that data then to inform our decision making. And I think that's the position that we find ourselves in, that we haven't been in previously. And that data is going to enable us to anticipate challenges, anticipate where there's oversupply, where there's undersupply, in a way that we haven't been able to as a system. I think we would all recognise workforce planning is dynamic, and we've had a number of changing elements in this, retention being one of them. It's a success that we've retained experience and skills in NHS Wales, and that's positive. Understanding the impact that has had then on vacancy levels and the opportunities is probably something that we've come to now, but it's one of a number of different factors. So I think the data is the piece that has been the game changer for us, and getting around to having those engaged conversations.
I'll bring Helen in a second, but just to develop that further then. So what you're describing is a set of challenges which you are telling me you think have been resolved, at least from a data point of view, that's sort of giving you the tools, as it were, to anticipate developments. So do you have a sense today of what might be the risks that lie ahead?
think we do.
Okay.
I think nursing remains a risk. I think paramedicine remains a risk for us. We understand there are some emerging issues around midwifery that we need to explore. I think the opportunity for us to work together as a system will enable us to identify different solutions. I think those are risks, but I think we can work together to look at different ways and different workforce models that will enable us to address those. And by addressing those, by understanding those risks earlier, we'll be in a better position to be able to mitigate any situation.
So all those solutions that you're talking about, what to just give me a sense. That's the aim, obviously, but what's in concrete terms, what does that mean that you are now able to do, or you're now preparing to do, which previously either you weren't or weren't able to?
So we've lived last summer. So I think if I think of the Swansea Bay situation, we worked with Swansea Bay to really understand what was potential. So looking at skill mix, looking at temporary spend, looking at rotations, looking at areas where maybe newly qualified nurses haven't traditionally gone, but actually with additional support, there may be different opportunities to do that. Thinking about community working and thinking about how we're supporting our direction of travel. So I think looking at some of our regional solutions, when we were talking to Swansea Bay, we also included Hywel Dda and Cwmtaf Morgannwg in our conversations. And actually both organisations were hugely generous in seeing this not just as a Swansea Bay situation, but actually as a regional opportunity. And I think taking some of that learning, I think if you think about paramedicine, traditionally our paramedics have worked in Welsh Ambulance Service, of course, but actually the skill set of that workforce provides significant opportunities across other services in health boards. So I think having this national body now, where we're able to, a national group now, to have those conversations enables us to really share some of those opportunities to mitigate. I hope that's helpful.
The regional dimensions of it. Alex, and I'll bring Helen into you.
Just one thing to add, we have a good system in place of meeting with every individual organisation throughout the year as well, through what's called our annual Education and Training Commissioner meetings. So it's a joint executive team meeting with every organisation, and James will have experienced these, where we do bring together a lot of this data and look at progress that's been achieved. We focus on quality too, but we also identify any significant changes in those workforce plans. So we have got a systematic approach to doing this as well, individually with organisations, as well as the collective approach that we've deployed there.
Okay, thank you.
Could I add just one thing? I have raised the awareness of the workforce and the training pipeline with our chairs, and I know Alex does this with the chief execs. I think the data is a very useful vehicle to demonstrate that, but we will always be up against the lag phase between the time we commission, the length of time it takes to train, and to finally come out. So the decisions made on commissioning numbers for nurses are 3 years ago. And the world has changed rapidly. So we have to be much more flexible as a body, as a system. And I think the evidence I can tell you now is the awareness of that rapidity of change and its impact on education commissioning is much more aware of board level.
So can I wasn't going to be able to say line this, but that's quite a good hook for this question, I think. So the flip side of it being decisions taken X number of years ago is that you can see the issue coming down the track.
Yes.
For some time.
Yes. And
so why these issues come as a matter of, I don't mean to say surprise, but you know, there's then there's a level of predictability which comes with that.
Yes.
So what's going on there?
So I think that clearly we have been having workforce deficits over the last few years, and I think everybody's been doing everything possible to solve those.
Yeah.
I think partly because of the lack of really good workforce data to inform those plans, there have been perhaps various separate pieces of work going on in order to address some of those supply problems. And I think what we would like to do is make sure that now with the data we can join all of that up. So things like decisions on international recruitment, changes in workforce models in order to address the fact that perhaps certain professions aren't available. And all of that really needs to come together through this new mechanism we've established, because I think you're right, the education and training pipeline is predictable. You know, we know what we put in and we know what we'll get out. It's some of the other factors that change around it that we need to really get a better handle on, and I think we're well placed to do that now.
Okay, thank you.
I was going to talk a bit more about the in effect the outflow data, which I know is something that Sian has worked on a lot over the last couple of years, and how that improvement in the data is going to get us a little bit more ahead of the game. So the data has become quite rich, I think, but it's how do we use it, isn't it? And I think the group is part of the answer to that. But I wonder if you'd just like to expand a bit more on the data side of it.
Sian Richards, Director of Digital Data, Comms and Engagement. Yeah, so thank you, Helen. We have made significant strides on the data and workforce data over the last couple of years. But I want to echo as well, we've done that in partnership with our NHS delivery bodies, DHEW and NWSSP. And what's that given us for the first time in NHS Wales is a single source of the truth through our data and analytics portal, direct access to dashboards, whether that's retire and return or whole-time equivalents or where people are being deployed. But on top of that now, because we've got a strong ecosystem and that collaboration, and we've got communities of practice that are going in on certain issues, whether that's RES or staff survey, to interpret that data, the quality is building, so we can start, and we have in the last 12 months built a systems dynamic supply and demand model. So for the first time in NHS Wales, we've got a supply and demand workforce model built off some of the learning in NHS England, and it's that, I think, which will start to answer your questions on the prediction of the future and scenario planning. So it can answer now for the what ifs, and then we can work through our mechanisms to understand the impact of that with partners.
I was just going to say that, and is there what more do we need to do around capacity for people to take that data and answer what questions? Because having a lot of data is good, but not
absolutely. So I think there's two parts to that answer: the skills and capacity of local teams, and we're supporting those teams locally to upskill, to be able to be more able to interpret and understand the data. But also we recognise we've made improvements, but there's more to be done on the data that is available to us. So we've got an initiative now with Cymtaf Morgano for a piece of work to start to link workforce and finance data. That again will help us gain another insight, or areas, for instance, that we've talked in some of the conversation already around how we map and understand skill mix, an area of work that we'll have to work with partners to really get into, and it's detailed in our IMTP now about how we'll take those initiatives forward.
Thank you. Captain.
Thank you very much, and thank you. So I'm just running through the scenario for the coming year, where number one, we know we've still got retention that's good, partly because of changes, environmental changes, and people staying at work longer, partly because we've got better retention in our organisations. We also know and beginning to understand the increase in staffing that we've had since 2019. We also have a financial challenge, so we know that actually that's not going to get easier in terms of placing students that are coming out this next year. So given that we've learned a lot over the last year, what do you think are the options that you will be discussing or putting to health boards about students that will be coming out the year coming up?
Helen, do you want to kick off on that? That's Ian, if you've got anything to add from a student perspective.
Yeah, I mean, I think some of the examples that we've given, I think it's people understanding that they're coming out and the job that they're going into might not be the job that they end up in. So actually, how do we give people the best experience with the best skills working in the best places? So rotations, giving people broad skills that enhance their employability and transferability into other services. I think as we're thinking about the design of our services, I think those community settings, I think there are lots of opportunities to explore. And as I said, I think the regional approach as well is something that we'll very much see that there are solutions. The issues with, if I take nursing, the issues with nursing aren't in all organisations. So it's understanding then from a partner perspective, actually how are we working together. So it's less about I go to this university and therefore I will be working in that organisation. I may work in that organisation, or I may work in a different organisation with a view to going back there. So I think there's something about how we're setting expectations, how we're communicating with our students, and how we're identifying what those opportunities are.
So I suppose what I'm trying to go is I think this year will be tougher for all organisations. And some of the opportunities we explored and utilised this year might not be available to us in the year coming. So I suppose I'm just asking you to think a bit more creatively about what we learned last year might not be applicable for this year. And I think you're right about preparing students for something different. It's what different that will be along with the health board. It's not just your responsibility, I understand, it's that with the health boards as well. But it's just urging a bit more creativity and thinking around that.
Alex, do you want to come in?
Yeah, because I think that one of the things that's clear when we've looked at some of the agency issues is that we know that the vacancies have largely disappeared for band 5s, but we know there are still vacancies in other parts of the nursing workforce. So some of this is about how do we also support our current staff in order to make that progression so that they can actually have a wider skill set, and be deployed into the vacancies that we have got in higher bands, and to provide room for some of these graduates coming through, which solves not just the graduate problem, but also gives us the opportunity to further reduce some of that agency. So, you know, we do need to look imaginatively around this. Absolutely take your point. It is going to be harder this year. And, you know, we are really conscious of that in HEIW. You know, going back to your point about accountability, we feel very accountable for these students, but we also recognise that actually our health board partners have got massive pressures on them as well. So that's the key, is to be imaginative together rather than us, you know, pass the baton, if you like, to them and say, well, these are your students. That's definitely not the approach we take. And I think by having all the organisations around the table, we'll get even more ideas on some of those imaginations.
Thank you.
Thank you very much. Okay, Chief Nursing Officer, and welcome. So I'm wondering about how the board is assured in terms of feedback from the learners, from the trainees, from the students across all of the professions in helping to shape your priorities. So we just had Jacqueline's question around prioritization. What are you hearing from your learners? What are they telling you, and how are you then transforming your approach, please? Because I'm sure they're telling you a story that doesn't always accord in the kind of the reality of training is just wonderful. We know that it's quite challenging. We know it's quite difficult. We know the reality is very, very different for them. So I'm just wondering what you're hearing, please.
Thanks, Sue. If I can ask Judith Hardest, where are you, Judith? Yeah, I can ask Judith.
Yeah, thank you. Thank you. Judith Hardest here. I'm an independent member at HEIW. I chair the Education Commissioning and Quality Committee, and part of the agenda on that committee each time we meet is to receive feedback through the contracting process on what our learners are saying. Now, that's our learners all across the different sectors. So it will be our postgraduate doctors, it will be our graduates and those in training. We also have something called the Speaking Up Safely initiative, which is particularly targeted at students to encourage them to come forward where they have concerns either about their university part of their programme or their clinical placement. Now, that is not a finished article. And we know from some of the other issues that arose where students haven't felt able to speak up until the end of their programme when they graduated. So we need to continually encourage them to come forward and see it as a safe space for them to be able to raise those concerns, and Ian could go into some of those details. So we receive reports on the National Student Survey. We have feedback through the General Medical Council inspection process, and they all come to the committee. But what we also do is look to see how we can triangulate that data. So if we're receiving feedback less than positive in a particular specialty, say in terms of training experience from, say, medical staff, the question will then, well, what data have we got around the nursing students who are also in that area? or the other health professions who maybe are working in that clinical area. And we bring that together so we can see, is there an issue within a health board that we can discuss with them when we have the meetings that Alex has referred to bring up those issues, rather than just make an assumption everything's fine apart from that group. And the data that Sean's already referred to really enables us to drill down and ask for explanations and look to try and triangulate that. And that's something that comes through to.
Thank you. To move on, it's a very good question. So procedurally, that sounds like you've got a really robust procedure. The question is really about how you're using that to inform and change your priorities. Is that a dynamic process for you? Is it informing your priority setting for the year ahead? So what have you heard in the last few years that will change your planning for next year?
Yeah, Ian Matheson, Director of Education Strategy and Transformation. It's a medium to long-term effort to try and gain the confidence of our learners so that they realise that they can speak up, and that's something we can't afford to take our foot off the gas with. We use a range of different approaches, and we do some triangulation of that. So our contract performance management framework has provision in it for multiple contacts with our education providers through the year, and that involves focus groups with a wide range of students. And we have staff going into there who are closer to student experience because they're closer to graduation, so they've got a legitimacy with the student body. So we inform the discussion there with information we're getting from our clinical educators and from the National Student Survey is a useful indicator as well. We can identify themes, and we take these out to the university. We test them with the student body. So we've got a wide range of metrics and approaches we use, and we triangulate those and we test them in real time with students. Where we identify issues, we then go back and we do follow-up visits. So we take groups of students that are affected by particular issues, and we follow up with them to determine if the improvements that we have been told about by the universities are actually feeding through to the students and having an impact on their experience. So we seek that assurance. The contract performance management framework has tended to focus on programme level, and what we realise is so the programmes that we're commissioning at the moment, they began in 2022 with some new contract arrangements. So we've just come through a full 3-year cycle with graduates from those programmes coming out in summer 2025. So we've been reflecting on that process and the adequacy of it, and we've introduced some portfolio level discussion. We're actually going higher up in the universities. We're actually looking at across the portfolio and trying to get assurance that there's proportionate attention being paid to the entire portfolio, so that there's not preferential attention in one area to the detriment of others. And that's providing us with some assurance that it gives us assurance that the health portfolio, the commission health portfolio, has got an important place in that university's portfolio programmes, and there's attention given to that, and it helps us to understand where there may be a need for other interventions so that we can follow up regularly. So we've got ongoing follow-ups with a range of programmes. Thanks, Ian.
I think just what Sue was asking as well was what specific improvements have we made as a result of the feedback. So I can think of some of the things that I've spoken to students about, which would include having a better balance of virtual learning and in-person learning, having much more notice of their clinical placement so that they can arrange all of their lives around that, because that obviously is really important. And obviously some qualitative issues around some of the cultural stuff as well that we've gone back in on. And I think that you will know about some of the discussions we've had around Bangor. And I think those are examples of where the action planning process that Ian described helps us land those.
I'm keen to move on at this point, so thank you. James.
Yeah, so the question I'm going to ask is relevant to this section, but also second to the next one. So I'd like to ask something around medical training, if that's all right. So a large proportion of the resident doctor workforce within Wales are locally employed doctors, and you are not commissioned to oversee locally employed doctors, but they are going to be the future consultant and SAS workforce in Wales, and their presence within departments, I suspect both positively and negatively, will have a direct impact on the training experience of postgraduate medical trainees. What risk do you think we're carrying as a system by your lack of oversight of locally employed doctors?
Good morning, Bore. Tom Lawson. I'm Medical Director in Health Education and Improvement Wales. So thank you, James. As you point out, the balance between locally employed doctors and resident doctors, the fundamental difference there being resident doctors are in formal training programs that are driven by the curricula written by the colleges, approved by the GMC, whereas the locally employed doctors work at the same level, but they're not necessarily being driven through those training programs. Training remains the most popular route, as we've seen from increasing competition ratios. But I think one of the really important things that's been introduced is that there are other pathways, and we should be valuing those as well. So people in locally employed jobs are doing the same roles at the same levels. They should be given the same opportunities.
Are there any gaps, so in fact you don't have oversight of them?
Well, we try and contribute. We have better data that we've talked about already, so understanding that, and the GMC provide us with good data, and that probably has been the largest increase in workforce numbers in the medical workforce numbers in the last 3 years, has been the number of locally employed doctors. We try and work, I mean, the partnership working that we talked about, we work closely with regards to that data, and we do provide some support. So the locally employed doctors, for example, access much of our training material that we provide on our digital platforms. We provide them with that access. We also provide them with expert information to guide them on how to capture their evidence of their competency. So if they are going down an alternative pathway to completing training, they can do that through that route. The challenge, of course, is from a system-wide thing, us not being able to factor that into the workforce planning as easily as we would be if they were all in training posts, but that is more robust now.
Okay, thank you.
Just sort of follow through on that one. So I would say that you have increasingly rigorous processes that I think are actually very successful on quality assuring at every stage the quality of training of postgraduate doctors, so that when they do become consultants and SAS doctors, I as a recent medical director had a very high level of assurance that I knew what their skills and expertise and their ability to fit into the team was. I think you're saying, though, that the information, whilst you're working very hard, is much more patchy on that other group of doctors who are really important for patient care in Wales. And do you think there is a risk that when they reach that stage of applying for career grade posts, we will not have had that information on the quality of assurance of their training?
So it is more patchy. I think the standards, and particularly when we look at our rural health boards where the requirements are more. So we are applying the same supervision standards or providing guides to our trainers. The challenge, of course, James, you're quite right, the quality assurance of medical training is very robust. There's an external assurance requirement there from the General Medical Council. Locally employed doctors use the same portfolios to capture their evidence and their supervisors sign it. If they then enter training programs, those competencies can count. That is part of the flexibility agenda that we do. So most of them still at some point enter training programs rather than complete their whole pathway through that locally employed thing. That is still the preferred choice for doctors at that level.
Thank you, Tom. Chris, we're getting on to the next item on the agenda. I've allowed the first item to overrun, but I've done that deliberately because there's a lot of ground to cover and it's a really important area. But as a consequence of my poor chairing, I'm going to ask for brevity all around to make sure we cover the ground that we need to cover. So the second item is on, we've looked at how you meet the current needs effectively. The second item is about how you look to the future and plan for future needs. Who's going to kick off on that from you?
Cabinet Secretary, thank you. I'm John McArthur. I'm one of the independent members and Vice Chair at HEIW, Education and Improvement Wales. And by way of a short introduction to this section, I'd like to highlight some of our national and Wales approaches and programmes, which address those workforce challenges that we've heard of and the opportunities, however, but really do focus on making sure that we have safe, efficient and sustainable service delivery here in Wales. So some of these programmes, they have immediate impact, and we've heard about some of those this morning around our attraction and recruitment. We've seen securing strong fill rates in some of those key specialties through our Train, Work, Live programme, and our All Retention programme is delivering measurable impact. We also have a focus on contributing to the national priorities through programmes that we lead on, whether that be on the perioperative workforce, urgent care practitioners, or women's health initiatives. So while some of these programmes have an immediate impact, of course, others are the building blocks and foundations for our future transformation. And I think it's probably one of the things I'd like to highlight here is the establishment of the 7 primary care academies, which are really going to be strengthening the professional multidisciplinary team and the ways of working in primary care, which is going to be so critical as we go forward. And complementary to that, and for across the whole system, is our national work on the digital skills development, which again, we all know we need to have in place. There are our strategic workforce plans, which have provided a coherent national approach to a more sustainable workforce in the short to medium term. And I think although this might be the first time there's been a comprehensive focus in some of those areas, and while they're not a replacement for a long-time plan, a workforce plan, they are an important driver of momentum. So everything we do, when we do it, we evaluate, we look for our benefits, that we can identify it in any of the programmes. It's totally embedded. And everything we do is also evidence-based and is a collaborative approach. We learn from others, we build on research, and we still with pride. I think that I hear that from the exec colleagues all times. We want to be strong in our engagement, and we engage subject matter experts as we need to in driving our innovation. I think finally, I'm conscious of time. I could go on a lot more, but I won't. Some of the key organisational challenges. We're a very ambitious board, and we want to make a difference. And it's a challenge to maintain focus and spread and avoid spreading ourselves too thinly as the demand for the national workforce planning increases. But we will continue to be responsive, agile, and work collaboratively with our partners to achieve it.
Okay, thank you, and thank you for your responsibility. So, Chris, I want actually to move away from the discussion about numbers, because you know, our narrative is, for obvious and good reason, that we've increased by X% over 5 years, by X% over 3 years, the numbers of various cohorts of the workforce. But that is not a sustainable pattern, that we simply recruit more and more people every single year into the future. That clearly cannot be a sustainable model. So the question really is, in your planning for the future needs of the NHS, how do you have a clear sense of what the needs from a digital point of view might be in 5 years' time, and therefore not just how many staff the NHS needs, but what skills they need to deliver that?
Well, I'll ask Sean to pick this up, but I have to say, predicting the future is going to be tricky, and therefore our view is we need to come up with viable scenarios to be ready to address where we get to. So, 5 years seems a very long time now in terms of medical technologies, the data, and also the effect of AI could really turn on a head. At the same time, you're changing to a community primary care based.
But I'm keen to hear what you're doing about it.
Right, Sean.
Okay, so to address the making a digital ready workforce, the back in 2020 as part of the workforce strategy, this was identified as one of the key pillars. So that early foresight that we needed to act and prepare the workforce to have the skills and capability to work in a digital environment. So since that workforce strategy of 2020, we've been building on our approach to getting a digitally competent and literate workforce. One of the key pillars of that has been the start of our digital capabilities framework. So staff can assess their digital needs. It's the first time in Wales that we've had a self-assessment tool, and we've got an evidence base of where people's skills are at. And we've had over 2,000 completions of that, but we're not stopping there and taking feedback. We're addressing feedback from our users about making that better, and actually looking at the modules of the education that people need, and also placing that to place-based care, and also how then that people actually look at the specialist skills they need depending on the model of care. And I think that's the piece that gets us into answering your question, is linking skills to the model of care that will actually be delivered virtually.
That sounds positive and important, obviously, but surely there's a larger question, isn't there, which is, are we in a position where we can, what are you as an organisation doing with partners, with DHCW presumably and others, to say, what are the scenarios, to Chris's point, for the delivery of services in, I'm saying 5 years, it could be 3 years or whatever, you know. So obviously skilling the workforce to be digitally literate clearly is important, but presumably there'll be jobs which currently exist which won't need to exist at that point, and jobs which we don't yet know what they will be required. So how do you know? What are you doing about that?
Absolutely, and I think that is an area where we haven't developed as much. We have been focusing on the area that Sharon's talked about, but we have got a joint objective being developed for our IMTP for next year with DHCW on, you know, how do we really start to capture people's imagination about the future, so we can work backwards from that and plan the workforce exactly as you described. And we are going to focus that around primary care in order to support the community by design work programme, to really think, you know, if we put all the opportunities we know we're going to have in the future and that crystal ball together, what does that mean for, as you say, you know, people not having to do work they're currently doing and actually different roles coming into place. So we aren't as advanced as you would like us to be on that particular issue, but we are. It is work in progress.
So before I bring the CMO in, am I right, Jen, Alex, in thinking that, you know, in 12 months, say from now, if whoever's sitting in this chair asks that question, you'll be able to say, well, actually, over the last 12 months, we've developed a model which gets us to greater clarity. Is that a fair expectation? Okay, thank you.
Borida, I'm Isabel Oliver, Chief Medical Officer. So thank you and congratulations on the progress that you've made with workforce supply and addressing gaps. And I'm also very pleased to hear you talk about your focus on health outcomes. So following on from the conversation just now, can you please tell us a bit more about how you are ensuring effective working with health boards to meet the future needs of the people who work? So that is to deliver better health outcomes, but also to enable new models of service delivery, such as you've mentioned the Community by Design program intended to deliver integrated services close to people's homes in the community. So how are you doing that, not just addressing current pressures in the workforce?
So I think one of the areas that we've been working on there is really that issue of enhancing clinical skills amongst a number of our contractor professions. And Donna, as our Vice Chair, is probably best to lead on some of the tangible examples of where we think that is really impacting on outcomes and service delivery for people that we want to be building on in the future.
Yeah, thank you. Absolutely. I mean, ultimately, it's why we're all here, isn't it? It's about those, you know, improving patient outcomes. And I think, as Alex said, some of the enhanced clinical skills in primary care. I mean, if we take an example of pharmacy and the common ailments service, the 27 common ailments, HEIW is involved in the mandatory training for sore throat and the urinary tract infection training, which was introduced in 2025. And the latest data we have from sort of November 2025 suggests that there have been 41,000 consultations that people have had in that area. And 82% of people, when asked, would have gone somewhere else. And that usually means a GP if they hadn't been able to access that service. So that's one of the areas. In terms of optometry, our professionals in that service have received training in preventative health and are using that sort of making every contact count approach, whereby they are talking about smoking cessation and have the referrals to smoking cessation have increased by 150%. So again, it's kind of tangible training, living to delivery, and changing into you know, care for patients. I could go on, but I know Cabinet Secretary, we
yes, please. So it's good to hear those examples. I suppose I was trying to think about how you're working with health boards to, in the evidence pack that you provided, you highlighted the fact that there had been some capability issues around workforce planning from health boards. And you highlighted how you are receiving information from health boards. I suppose I was trying to understand how you are working in partnership with them and bringing your own insights about the art of the possible into the development of new models, into changing how we deliver services so that they best meet the needs of the population, and how you're working with them to translate, those evidence of sort of engagement and satisfaction with new services into actually better health outcomes.
If I can just pick up a couple of points on that. So absolutely, workforce planning is something that needs to be improved in most services, but particularly in primary care, where it's probably been less of a focus. So again, we produce some specific training and resources to support our primary care colleagues and health boards to improve that. We've also, through the primary care academies that we've supported, we've got really great routes, if you like, into very local examples of what health boards are doing to change models of care, new demands and new requirements for skills amongst the primary care workforce that is feeding back then into new programmes that we can then roll out across Wales. So although not particularly forward thinking at the moment, but MSK frameworks for our first contact physiotherapy practitioners, which should be in every place across Wales by now, but aren't yet. So points for them, how we support and future proof our general practice nursing workforce will continue to play a really strong role within those networks, but also thinking about inequalities. How do we really focus on population health through making sure that we're focused on inequalities? So I think there are a range of ways in which.
How do you, sorry to interrupt you, but how do you do, how do you see your role in helping address inequalities for example?
So very much around making sure that we're training people, we are allocating those to areas that we know are most in need, and that because we know that if you do that, the people are likely to stay more closely. So again, our GP training program's been working closely to look at making sure that training practices are right across Wales, but also working with HEIW Cymru on some of their priorities as well. So having those connections, Public Health Wales, and really focusing on that preventative end. Thank you.
Thank you. Helen.
A bit more about population need and the experience of individuals in their health and care system. So we know we have an older population with comorbidities. So how are you thinking about skills in that context? So, you hear experience from the public, don't you, about I had to see this person for my diabetes and this person for my bad hip and that person for the other thing that was happening to me. And so people are either on lots of waiting lists or waiting for lots of treatment tests from different angles. In terms of thinking about skills, are there things you can do to address some of those longer term population needs in the way we train and develop and retrain our existing workforce?
Yeah, I think that's a really important point, Helen, because I think one of the things that we're very conscious of at the moment is we need to move more from a roles perspective to a skills perspective, because the key to future workforce planning is going to be to have a flexible workforce, a more flexible workforce. And we know that today it's quite rigid in terms of professional boundaries when we train people to work in that way. So that is one of the drivers for our education strategy, in fact, which is this issue of needing to have a more generalist approach, a more generalist core, so that we can develop those core competencies and look at more interprofessional training to really support our future workforce. We already do some of that within our undergraduate programmes, and certainly the last couple of years that's increased. There's a real emphasis on that through the medical reform programme that Tom will be leading, that's come from the UK Review of Medical Training, around how we reinvigorate a more generalist approach. So that'll really be at the core of our approach going forward. But I think in terms of that frailty issue in particular, then we are very much working with colleagues in the strategic programmes for primary care and urgent and emergency care on how do we support staff in terms of frailty, how do we make sure that people have got the right skills in the right part of the system. We do a range of CPD for our general practice staff, which also helps them with how they need to manage those comorbidities and multimorbidities more effectively, so that we get the right outcomes. So I wouldn't say we've got a defined approach to that question yet, Helen, but we're very conscious of the fact that we need to move in that direction over the next 12 to 18 months.
Okay, Health Secretary, I'm a GP by background. You are the, God bless the generalist. The time of the generalist is coming. And when we look at recruitment into care of the elderly, for instance, at postgraduate level, it is not good. I think that the generalists, the reform of education must take us towards strengthening the length of time people keep their generalist skills, re-enhancing their general skills as they enter their more specialist era. And I also see a position where the generalist will be a constant as part of everybody's career, in medicine in particular. And the specialist bit, they'll dip in and change during a very long career. They'll have to because of the technologies and because of the needs.
Thank you for that. We're going to move on to the third item of the agenda. I've been very keen since I've taken on this role to focus on how we can strengthen leadership capability and capacity at all levels of the system. So we're going to explore your role in helping with that part of the agenda at the third item. So who is leading for you on this, Chris?
Helen.
Thank you. And thank you for the opportunity to provide some introductory comments. Excuse me. So we know that the system is under sustained pressure, and we know from both our staff and operational evidence that leadership capability is one of the strongest drivers to service delivery, to culture, to staff experience. HEIW's role has grown accordingly, from delivering programmes to leading a national Once for Wales approach to leadership development. We started from a place of no leadership programmes, and from that we have built a coherent national leadership offer for the NHS in Wales. However, system intelligence shows that there's a gap below executive level, particularly among operational managers, clinical and ward managers, ward leaders, primary care and some clinical teams. And strengthening leadership here is essential for service delivery, improvement and our future pipelines. The new UK Management and Leadership Competence Framework will create for the first time regulated expectations for leaders at every level and underpinned by a consistent curriculum. We are representing Wales in its development and have been ensuring that NHS Wales leaders have been engaged at every opportunity. This will accelerate national pathways, consistencies and clearer expectations for leaders across NHS Wales, and provide a unique opportunity to move to a single national model that removes duplication across the system. We have a full suite of national programmes from aspiring executives and accredited clinical leadership to the graduate programme, and new offers for operational managers and primary care. These have been directly shaped by the system and by our data. We are seeing improved confidence, we are seeing progression into senior roles, and we're seeing strong graduate retention and more consistent leadership across organisations. Our staff survey intelligence will help us target development where it can shift culture and performance. But looking ahead, we know that there is absolutely more to do. Our challenge is scale, demand is rising, expectations increasing, and the regulation piece is absolutely evolving. A cohesive One Wales model will be vital to avoid fragmentation and ensure that the leadership development that we offer delivers safer cultures, better staff experience and operational improvement, and ultimately leading to better care for patients.
Thank you. So on this, you talked about a Once for Wales, but we do not have a Once for Wales model. We have a Many Times for Wales model in this space. So I understand the picture that you've painted is positive as where we want to get to, but where we are today is not in that place. We have each health board running, well, maybe not each, but many of them running their own courses. I don't have a sense of whether they're similar, whether they're better or worse. I mean, so why are we in that position, and what is your role in changing that? And crucially, how will you do that? What are the measures? What are you if you're running a health board and you've got your own leadership program, why are you going to stop doing that and doing the HEIW and do the HEIW instead?
So yes, we had recent discussions about it. And the reality is that health boards were set up to do their own leadership development. So that's right and proper that they're looking to invest in their own staff. And since HEIW has been established, obviously we've been reintroducing a number of different offers, but we have focused on the smaller cohorts, i.e. the more senior cohorts, because that made more sense to start with for a once for us offer. We all recognise the need to have a more consistent approach and a good quality approach, and that leadership framework that's going to come in for the whole of UK will really drive that. And I think the key to that is making sure we provide offers that meet needs, that can be relied upon in terms of quality, that people think they can access fairly. And I think that's what we've demonstrated with the programmes that we've had so far. I think that's what we've demonstrated, and we've got waiting lists for some of them, like the Advanced Clinical Leadership Programme. So I think we'll see a real transition over the next couple of years, where actually, in order to make sure that managers feel that they can meet the competencies that are now set for them at all levels, that actually that ask for more national support will grow. What we need to do is be really agile with the resources we've got, because we've talked already about the fact that money is limited, and we need to look at how do we provide these in a more imaginative way going forward, not rely so much on the expensive programme for just a few chosen people, but actually how do we make leadership development and management training available in a more bite-sized form, looking at different blended models of delivery. So an example of that is obviously the ops management course that we're looking at the moment. And just to assure you, I know one conversation suggested that everybody was still doing what they were doing. However, I did check with my colleagues afterwards, and what they are focusing on is the more senior managers, not that group in the band 6 to 8As that we're really focusing on for that new national offer. The pilot's finished on that programme. It's evaluated really well. We're just about to procure now to go to roll out of that ops management approach over the next year to 18 months. And we'll be launching that at a conference at the end of March, which we're going to be calling Excellence in Operational Management, where we can really enthuse people with the fact that we're going to be investing in them through that programme.
And taking your role as system leaders in this space, as the starting point, what's your sense of what the most ambitious version of that can look like? So, what's the largest cohort, most quickly, deepest blend of skills, greatest impact? How does that look?
I think that, well, in terms of our ambition, we think we need to convert our programmes into more of a leadership academy, supported by our Gwella digital portal, which actually is very much inclusive for all of our leaders and managers. And I think giving people the opportunity to do that self-service approach and actually that self-assessment and get themselves the learning they need will help everybody potentially. But I think that ops management is the way in to get into the biggest cohort. And I think the figures that we shared with you previously were in that group. We anticipate, the coding is not excellent on management roles yet, but we anticipate there's around 1,000 to 1,200 people. So if we can really roll out that training over the next year, we've really reached a much bigger group of people that have such a big impact on service delivery, quality and financial management. They are absolutely critical.
And if I was a health board manager at the right level, why would I not want my staff to be doing this course?
Well, the things that sometimes constrain people are, time out of work. So we've made it as agile as possible in order to meet that need. We have worked really closely with the chief operating officers and with the chief executives to make sure that it meets their needs and that they're supportive of it and that they are participating in it. So hopefully there's system ownership of that.
You've also got to share. Let's go up to an excellent topic, which is excitable to me. I've got another question, which I'll come on to that. Jacqueline first.
Thank you very much. I forgot to introduce myself before. I'm Jacqueline Potterdell. I'm the Director General for Health, Social Care and Early Years and Chief Executive NHS Wales. So obviously leadership for us, all of us here, is a really critical thing, particularly to enable our health boards to be well and well managed. So there are several bits to this question. Firstly, we know that we are not finding the chief execs of tomorrow. We aren't yet ready at the exec level to do that. So how are we going to make our executives ready for chief exec posts? Because it's not just about understanding value-led leadership, which is absolutely right. It's actually understanding the nuts and bolts of being a chief executive, because once you go from one to the other, it's a very different bit. Being the chief strategist and master tactician is something that we don't help or support. So what do you think your role is in some of that? There's also then the bigger question about how do we also ensure, not just about how we get through the executive leadership, but how we also develop our IMs and our chairs, future chairs, to actually be able to chair health boards in a way that we need, that people are excited by that they feel prepared to be able to do that, and that we find we're able to, finding IMs is quite hard. So thank you, all of you who are there. But, we do, how do we begin to work with you about how we actually do that? And once we've got people in post, support them, and a lot of my time is spent coaching and supporting. And I don't mind that because I think that's part of my role. But how do we make sure that we have sustainable, well-supported leaders in our organisation? And what do you think your role is in doing that?
Yeah, I mean, there's lots, there's such a lot to be done. We would absolutely recognise that, and what we've done is put some foundations in, but we need definitely to build on that. So I think in terms of the executive issue, I mean, that has become really clear, hasn't it, in the last sort of 6 to 12 months, both in terms of applications we've seen for aspiring directors, but also aspiring chief executives, and some really good talented people that perhaps haven't always had access to the right experiential pieces that have supported them through. So I think, that's within our control as a system, isn't it? And I think our role in HEIW is to help people navigate that and to help set some guiding principles around what kind of pathways we should be putting in place for some of those development opportunities within health boards, because we could do a lot more within what we've got, and probably we're not thinking in that lateral way at the moment. One of the things we've thought about before we haven't had a chance to get into this is, whether we have almost an opportunities bank for senior leaders to enable them to do special projects, secondments, part-time working, expand their experience, not just in Wales, but certainly, I've had the benefit of doing consultancy work in Scotland before, and having that kind of sort of twinning arrangement with other nations and other systems. So I think that's really critical. And we've dipped our toe into the water with a bit of the Denmark issue as well, and we need to build on that. I think the IMs and chairs is definitely something we haven't done very much on yet. We have introduced this year a board the board induction programme, but that's very much the tip of the iceberg. So we'd be very pleased to work with you on developing that. That's a priority.
Thank you. So building leadership, effective leadership pipelines is really crucial within Wales. I'm wondering what HEIW's strategic role is in addressing the workforce race equality standard across Wales. The data is shockingly poor, has been stagnant for a long time, although we're only measuring it now. We have international nurses and other professionals for up to 20 years who are struggling to break through. I'm wondering what your leadership programs have shown in terms of impact, progress, and what actions you're taking. What is the board's commitment to helping us address this problem?
I think it's a very well made point, and we absolutely recognise that our leadership development will provide part of the solution. It's not the only solution. So you will have seen from the evidence pack that we have recently introduced the Step Into Leadership programme, and that's the aim of that is to provide leadership development for our future Black, Asian and minority ethnic leaders in the system who haven't had specific opportunities raised to them. This programme is in the early days, but we're taking huge learning from it. We're talking in the design and the development of the programme. We took soundings from people with lived experience, and thank you for your support with that, because we're in early days, but actually the feedback that we're getting from those participants is hugely rich and hugely generous into informing how else we can do it. We've talked about the framework. The framework will give us an opportunity to revisit how we are doing leadership and actually how we're embedding our diversity requirements within that. The framework reaches all leaders. And I think by building this in specifically, taking the learnings from this one programme, appreciating that it is just one programme, but it is a start, and taking that learning and building it in through our programmes is a key way of doing it.
So it's too early to tell, basically, is what you're saying from an impact perspective, and I appreciate that this is the first programme. So I guess in a year's time, when we're sitting here and you've got your 24 people who've gone through your cohort, what are you anticipating will have been impact? Because going through a program is one thing, having the opportunity to be able to apply is another, having exposure to operate in that leadership realm is another. So just wondering, what do you anticipate a year from now for those people?
So the aim of this was to give them the confidence and the skills and the development to enable them to progress. I'd like to see them progressing. I'd like to see them in roles that they felt they weren't equipped to do or felt that they had available to them previously. So I'd like to see that.
One last thing. So I think the onus on the individual, assuming that their capabilities, the issue might need a different mindset across HEIW, because it's not always an individual capability issue. It's a system issue that needs addressing. So the question is, what will you do in your leadership programs to enable the system to change the mindset, to understand capability doesn't show up in just one way or stereotypes?
Sorry, the point I was just going to make. In the design of the programme, all of the participants have an executive level sponsor with the support in an organisation and raising awareness of their experience through the programme and in their work. So it's how we're building that. It's cultural change, and it's how we're making that start.
Can I just add a bit more, because I just want to go down this route a bit more. So I think where Sue's going is we shouldn't just be. It's great we've got a programme for our global majority staff. It's great they've got executive sponsors. So there's two parts of this. Number one, how do you actually use the res data, the national res data, to inform the rest of your courses to actually be able to understand their own biases, understand how actually that comes out in our res data. So it's not just about the global majority staff that are on that course, it's about the other courses and how you actually weave that through. And also a question for you, Chris. Have you, as a board, looked at the national res data and understand what it's actually saying to help you when you're planning these courses?
We've had training in unconscious bias. We have seen the reports. We are very aware of differential attainment in our medical training in particular, and we are very aware of differential attainment at universities. So we're not on our own as an institution. This is a pernicious issue. It's not something I feel we can say it'll ever be finished. I think this is turning a big tanker, and I absolutely agree. It's not just about the person who puts themselves up for the training. It's about how the system reflects and deflects their own biases. And I think that honesty and openness is where we need to get to, and that's not comfortable. So that takes us right back to the chair's role and setting that culture right at the beginning, and a constant effort. It is not a journey. It is a journey. It's not a day trip.
I want to ask one final question in this area before we move on to affecting the organisation, which is we've discussed the number of the programmes today. And I guess those that are in a career progression, I can use that term, that may not be the full purpose of them. But you can measure whether your aspiring chief executive programme is working, presumably by the number of people who come on to become chief executives in due course. So that's presumably a metric. But if the task in hand is to improve leadership capability at all levels of the NHS, how do you know if any of this is working?
So we are looking at how we expand the evaluation of our programmes, because, as you say, there's a very tangible, did they get another job or didn't they? But actually what we want to see is what's the impact on not just their personal progression, but the people around them and the impact on service delivery. And that is quite a difficult evaluation, but Helen might want to pick some of that. I think that one of the key pieces of data, and the reason why we've been so passionate about pursuing this, is the NHS staff survey, because I think that is the barometer that we haven't had before in NHS Wales. yes, the response rate is still not good enough. It's going in the right direction slowly, but you know, we need to put our effort behind it, because I think that gives us and gives all organisations the opportunity to really deep dive into exactly that issue, because we know there's such a direct relationship between leadership and culture and staff experience.
And if in that broader evaluation, just briefly, if you wouldn't mind, is it realistic, do you think, to get to a place where you could evaluate not on this cohort, but on the improvement of the system overall, the contribution which improved leadership support can make to that? Do you think it is possible to get to that level of broader understanding?
When we come to interviews, we go through a SIP process. I would like to see a situation where more people were coming through, maybe for interview, but not necessarily. And we are identifying more support that we can give them to get there. So I think that it's about a velocity rather than an end point, perhaps, will be the first indicator.
Can I just answer that?
Yes.
So I think this area is one to absolutely be explored, and we probably can't do that on our own. And I think that's where we need to be. No, I think that's where it's partnering with research and with university. I think we're undertaking a longitudinal study to understand the impact of our programmes on some of our clinical leaders and understanding what the difference that's made on their career. As I said at the outset, leadership is an indicator of culture, of staff experience, of operational delivery. It's indicator of all of that. So whether we can see exactly that leadership programme and that patient, but it is absolutely a driver of those improvements. And I think seeing it in the round, one of the pieces of work that we're in discussion and certainly through our planning is almost looking at leadership, culture, how we're monitoring that, as well as some of our more transactional ways, sickness, absence, and period, but actually seeing that in the round to understand then the performance of a team, of an organisation against their operational performance, and seeing stronger links. We'll then be able to answer that question.
Okay, thank you. We're going to move on to the fourth item in the agenda, which is around what you're doing as a board to strengthen the organisation. Who's leading on that, Chris?
Okay, Diolch. Thank you. I'm Glyn Jones. I'm the Director of Finance, Planning, Performance, and Deputy Chief Executive in Health, Education and Recruitment Wales. I would just say very few brief words about how HEIW is trying to strengthen itself as an organisation, conscious that we're always trying to improve what we do. I think it's important to say we have strong internal arrangements which very much focus on how we deliver both value, but also value for money in everything that we do. If you look at our workforce model and the way that we've developed this, we operate a strong core workforce, which it certainly aims to be agile, have specialist workforce skills, but at the same time, we also have a number of fixed-term posts that focus on short-term, time-limited priorities as well. So I think that gives us a really good flexibility within the organisation. If you look at our performance, we remain in routine escalation. We do everything we can to try and manage our resources flexibly within the organisation and between different programmes as well. And I know we've talked about some of those areas earlier. We're always very open to accountability. And I think if you look at some of the Audit Wales reports that we've had on things like structured assessment, cost improvement arrangements, these are very positive in terms of how we work as a board, our governance, strong scrutiny that exists through the organisation, but also sound arrangements for looking at things like cost improvement opportunities, how we identify those and then deliver them. So this is something that we're constantly looking to improve on. So conscious of time, hopefully that just gives you a very brief introduction.
It does. Thank you, Glenn. So you mentioned the Audit Wales structured assessment, and I think one for 2024 said there had been that the arrangements were robust and, and that they identified inevitably areas where, there could be even more focus, if you like. And one of those Sue touched on earlier, which is hearing the voice of students more clearly, and we discussed that. But another one which Audit Wales referred to was having a clearer, crisper sense of the impact and benefit of particular plans, particular strategies. So what's changed since then to further strengthen that clear connection between plan and strategy on the one hand, and crisp identification of the impact and benefits of that on the other?
Yeah. In terms of our planning approach, something we've done certainly over the last 12 months or so has been to look at that more strategic approach. We talked earlier about forecasting, but also being able to do scenario modelling, so understanding the real world and what may happen. Our strategic planning approach, we've adopted a model called 3 Horizons planning model, which very much allows us to look at what we see that strategic future looking like in 5-10 years' time. We spent quite a bit of time looking at that as a board, and also through the organisation.
And are these all new developments since then?
Yeah, in the last 12 months, it will feature very heavily in our integrated medium-term plan for this year as well. We also use it and will continue to use it for the annual education training plan as well. So yes, this is something that the organisation has embraced really well, but I think there's more work to do in terms of embedding it fully, and also making sure that the wider system works with us in a more strategic way.
Yes, maybe linked to that, if that's okay. So how are you then using that information to prioritize the work at the board level? Because the evidence that you've provided and the discussions today highlight that there's demand for new programs, multiple programs, and obviously we live in a time of financial constraints. So how do you then prioritize at board level in terms of how to allocate the resources?
Anne might want to come in on this point, but clearly we start with the remit letter and the Cabinet Secretary priorities, and that has to be at the basis of all of the prioritisation that we do. But Alan, did you think that?
Alan Lloyd, Aelod Annibynnol. Prioritisation and looking at values core to what we're doing. We recognise everything's in a resource constraint, so prioritisation to us is very much focused around our planning. So in terms of the IMTP, how it fits in with the remit letter, and also sort of the allocation letter fits within there. With regards to the education training plan, we're looking at there in terms of demand, capacity, and the resources. And clearly, demand is an issue which we touched on earlier in terms of what's coming through in terms of previous ETP plans, what the service is asking for us in terms of places, as well as medical school outputs coming through in all of that. So we are prioritising through those processes and giving examples. Some of the things we're looking at is in terms of how we flex resources, how do we phase implementation, but also deprioritise. So physicians and associates not taking those forwards. So we're looking at that. And that's
done that. So that was a second. That was external to the organisation. Effectively, that shows there's sort of the landscape changed. So other examples of things which you've made a choice to deprioritise as an organisation, other than in the context of the changing landscape around you?
Yeah, so as well as that one, I mean, obviously, in terms of the mental health arena, there are the clinical applied associate psychologists as well. So again, part of our mental health workforce plan was to develop these new roles. Again, we've worked very closely with health boards to try and take forward those roles, but we know that where there is potentially insufficient demand for those roles in the near term, again, we've looked at the data, we've talked to partners, we've taken a view that actually, again, that's probably an area that we should pause for the time being in terms of commissioning those education training places. So that's probably one area.
Can I just make a point on that, because I think it's a really important question, and I think what we don't like to do is say no. we don't like to say no to things that people want us to do because we want to be there to be helpful. So sometimes it's not about saying no completely, it's about saying, okay, let's start this off and see whether there is something we do to make progress rather than perhaps do the whole thing. So an example I would give you around that is a lot of the national programmes and the clinical networks want strategic workforce plans in all of their areas. And clearly, you know, not only do we not have the resource to do that, we don't necessarily have the resource in the system to implement them either. So what we would do there is say, okay, what question are you trying to answer? Let's see if we can come up with an answer to that that gives us a bit of progress over the next couple of years, but perhaps isn't the whole solution to all of those problems. So I think it's working creatively within our resources to try and make progress all the time and not leave partners without any support.
Okay. Just a final question from me, Chris. So what's the board's understanding of the international landscape in this space? And what have you learned, or, you know, for good or ill, from other jurisdictions who are facing similar challenges?
Lots to pinch.
Yeah. Pick up on, I think it's a broader question you're talking about in terms of workforce. So over the last 12 months, we've actually become involved with the World Health Organization collaboratives on workforce planning and digital workforce. And that's just given a huge wealth of data and information about how other countries are addressing these problems, how they're using their resources differently. And that's definitely something which we'll be building on into our own.
Great. Thank you very much. We've reached the end of the agenda together, Chris. We have a couple of minutes. If there's anything that you feel you haven't had an opportunity to say, which you're keen for us to hear, now is a chance.
I think it's been really valuable, and I hope the pack has given you some idea of the breadth, depth, and commitment.
Yes, and for those watching, just to be clear, necessarily these meetings focus on areas where we're looking for more assurance, and so the areas where we are very assured often don't get picked up quite so much. So that, as you say, set up in the evidence pack, and I hope that at the start of each agenda item, when your colleagues have been able to set that new stall, as it were. So, diolch yn fawr iawn. Thank you all for your time. I will just say in closing that of the themes today, the three things that I think have stood out for me are working on that agile workforce planning model, where there's a more real-time understanding of some of the challenges which are emerging. Secondly, having developing a clear understanding, in particular, about the relationship between technology change, digital change, on the one hand, and not just numbers, but the mix of staffing on the other. And I'll be looking forward to seeing what the conclusion of the next year is in that area. And then lastly, really, the contribution of leadership training to improvement in the system overall, and developing with partners as clear an understanding as one can of whether what we're doing is actually improving the system. But thank you very much for an interesting discussion.
Thank you.